Hi, I'm Dr. Kenneth Qiu, and I'm here with Dr. Eric Bricker. Thanks for joining me, Dr. Bricker.
Thanks for having me, Dr. Kenneth Qiu.
We're here in Dallas, which is where you're based out of. Why don't you give us a little intro for who you are and what you've been doing?
My name's Dr. Eric Bricker. I'm the Chief Medical Officer and co-founder of AHealthcareZ, which is healthcare finance explained on LinkedIn and on YouTube as well. I've got like 300 videos that explain the ins and outs of healthcare finance. And I'm the former co-founder and chief medical officer of a patient navigation company called Compass Professional Health Services that was acquired back in 2018. That's when I started making my AHealthcareZ videos. And now I'm fortunate enough to be the medical director for SimplePay Health, which is an alternative health plan. So anyway, that's enough alphabet soup about me.
Yeah, that's awesome. And I will put a link at the bottom of the video with a link to your AHealthcareZ videos.
Okay,
they're fantastic. I've been watching them for about 2 years now. You definitely cover a huge range. You have both breadth and depth to the content that you cover. And if we try to cover everything, we could probably go on for hours. I think for today, what would be interesting, because at X equals primary care, we're solving for the X in primary care, let's dive into some primary care topics. So one of the things you've covered is value-based care and direct pay, which you call claims-free care, or have used that terminology. Mm-hmm. So when it comes to these two different models, what do you see as the difference, and do you have a preference when it comes to picking and choosing your favorite one over the other?
Value-based care means a whole bunch of different things to different people, right? So it's sort of this nebulous thing, and one way to just not even have to deal with fee-for-service and all of the complexity with billing is just to deliver care without any claims at all. So you can deliver care without claim, but there's no law, there's no state law that says you have to bill a claim in order to deliver medical care. So one of the great things about direct primary care is that it's care without claims, as so are like on-site clinics and near-site clinics, or there are even virtual primary care companies that also do care without claims. And so really what that is whether you want to call it capitation or a subscription model, or typically it's some sort of fixed fee, whether it's per person or per population, whether it's per month or per quarter, what have you. And it oftentimes is then for unlimited use of the clinic or the direct primary care practice or what have you. And this does a couple of things that are advantageous. Is that one, it separates the physician from the financial need to have as many visits as possible in order to bill as much as possible, therefore in order to get paid as much as possible. Mm-hmm. Which, especially in the primary care setting, like that doesn't make a lot of sense, right? Because, well, I won't even get into why that doesn't make sense. We'll just say that doesn't make sense. So when you have a separation between, let's say, the length of the visit and the complexity of the visit and the number of visits, just like completely separate out the money from that. And essentially what you do is you then have a physician who is on, if they're a DPC physician, do you have a physician who's on salary? And let's say their salary is like 50% of what the overall subscriptions are, and then the other 50% goes to keep the lights on, pay the bills, et cetera, pay the rent for the space. Then, in my opinion, one of the best things for patient care and one of the best ways to practice as a physician is to practice in a salary format, so that you don't have that perverse incentive of fee-for-service of doing too much in order to make more, but then you also don't have the inverse incentive where you would get paid more for doing less. Like if I was a patient, I wouldn't necessarily want to go to a doctor who would get paid more to do less, mm-hmm. because they'd be like, oh, you're fine, just walk it off. Well, no, I'm not fine. I mean, please do something about it. So that, in my mind, and I was very fortunate in that when I was a resident, guess what? I was on salary. Mm-hmm. When I was a hospitalist physician, guess what? I was on salary. And it was an incredibly freeing way to practice, because then you could just focus on the patient care. Now, from a value-based care, from a value perspective to the patient and then to the payer, and the payer could be the federal government, it could be an employer, etc. The value in that sort of care without claims arrangement is that it really puts primacy on primary care in addressing chronic conditions when they are smaller versus when they are catastrophic and require heroic interventions on the part of the specialist. I don't like to use the word preventive care because then people are like, okay, U.S. Preventive Services Task Force, we're talking about mammograms and colonoscopies and blood pressure screening, and all that's important too. But really what it is it's treating disease, right? So it's not necessarily quote unquote preventive care. So
right.
like you're treating somebody with hypertension, you're treating somebody with diabetes, you're treating somebody with high cholesterol, but you're doing it when it's a much earlier phase and a less severe phase of the disease than later. Because in the fee-for-service world that we have today, physicians get paid more and are incentivized to play superhero, to play Superman, right? And in order to have Superman, you need to have people in a desperate situation, right? And I personally am not I would rather prevent people from being desperate in the first place. That's what I would prefer to do, right? And sure, it's fun to play Superman and everybody pats you on the back and you get congratulations and blah blah blah. But wouldn't it be better if you just didn't have people in these horrible, distressful situations to begin with? And I think if you can that can be accomplished through care without claims better than any other way.
So then really teasing that out, because again, there's capitated, so for example, like Medicare Advantage, that is through the vehicle of insurance versus direct pay where it kind of gets rid of that middleman. Do you think there's any fundamental difference between these two models in terms of outcome and incentives?
Well, so the short answer is yes, because at the end of the day, the Medicare Advantage plans potentially could be financially structured for the doctor such that the doctor would get paid more for doing less. Now, it doesn't have to be set up that way, but it could be such that, hey, you're getting X amount of dollars for, let's just say it's $12,000 per beneficiary per year. And to the extent that you have a beneficiary that goes into the hospital a lot, well then you, as the Medicare Advantage primary care doctor, you might get paid less. And so therefore you might do all sorts of things, whether it's cherry picking your patients or lemon dropping your patients or just telling them to walk it off and not go to the ER when they probably actually do need to go to the ER. So again, the ideal, and all of it, this is not a new concept, right? This is what the Mayo Clinic does, this is what the Cleveland Clinic does. W.W. Mayo, the founder of the Mayo Clinic, he realized this in the late 1800s. He saw this dynamic of you really shouldn't pay fee, because he saw 19th century doctors doing too much because they were getting paid, not insurance, but they were still charging their patients and they were doing more than what they should have done. And then when you add third-party payment, that just throws kerosene on the fire in terms of doing that even more. So again, it's not a new concept. It's done also by the majority of academic medical centers in America. If you're teaching attending physician at a university hospital, you're typically on salary, right? And so now, what do all salary positions also have? Look, you got to show up to work, you got to see a certain number of patients, you got to answer your phone when your phone rings, and so do you still have to work? Could you potentially be fired for not working the appropriate amount? Of course, like every other salaried job in America, right? So I don't think it's impossible for the medical profession to do that.
So you mentioned all these different institutions have had this idea for years, and you actually have a video on it, right? We did this 40 some years ago or even longer, you mentioned. Why is it then, are we still majority fee for service right now? Why hasn't everybody just established a salary system?
Yeah, so it's a great question, and as many healthcare aficionados have said, correctly so, it all goes back to Medicare, right? And that's where so it's great that we're in Dallas, right? Because actually health insurance was invented by surgeons at the Baylor Hospital in Dallas.
That's right.
And before Medicare. But that was obviously just local for, teachers in Dallas. It wasn't nationwide. But what really made the whole process of third-party payment sort of institutionalized, if you will, was really Medicare. And then everything just kind of flowed from that. And so when you have payment from a third party, it's the sort of cynical golden rule, right? Where he who has the gold makes the rules. Mm-hmm. And so if you have the money, well then you want to control it. And so that is being changed slowly over time, and really the whole Medicare Advantage capitated direction it's not a perfect manifestation of that, but it is closer to a manifestation of care without claims. Let me give you an example. So there are physician practices that see Medicare Advantage patients where their EMRs, they built them completely themselves because they're not designed to the bill. Guess what they're designed to do? Do clinical workflow and actually communicate what's going on with the patient. Right. And they looked at all the other EMRs and they're like, this is not very helpful. Like, we don't need to bill. All these EMRs are so focused on billing that, let's do it ourselves. And guess what? I guarantee you their patients get better care as a result of that EMR that they use because they were paid in a different way.
Right. And so taking a little bit of a pivot, one of the things that has arisen during COVID has been around in the direct care community for a while, but COVID gave rise to telemedicine. And especially in these salary capitated models, people really like the virtual care. And so I think in the last couple of years, virtual first or virtual only primary care has kind of shown its head, and there are a lot of offerings for it. Compared to brick and mortar, what do you see are the benefits of virtual care, and do you think virtual primary care will ever exist by itself, or do you think it'll always have to pair with brick and mortar somehow?
Yeah, so the real benefit of virtual primary care, and whether it's virtual first or you could have an in-person visit first and then have all your subsequent visits be virtual, is really around access. Because at the end of the day, when you talk about triple aim, quadruple aim, quintuple aim, we got a whole bunch of aims, right? So one of those aims is access, right? At a very basic level, the doctor-patient relationship can't be formed. You can't make a diagnosis. You can't come up with a treatment plan, et cetera, unless you actually have access to the physician. And access isn't just about money. At a very basic level, it's about the two. We live in a four-dimensional world, right? Space and time, mm-hmm. right? And so the space is a real problem in terms of actually getting into the clinic, especially in two places, right? Cities where people don't have a car, they rely on public transportation, and so I lived in Chicago for 10 years. That's why I went to medical school, right? It's cold, right? Yeah. So you're gonna take the L, you gotta stand outside in front of underneath these French fryers to keep you warm when it's negative 30. You don't wanna have to deal with that. And if you're sick, it might actually be bad for you. Let's say you've got reactive airway disease, right? You're gonna go out in negative 30-degree temperatures to go to the doctor. Well, shoot, going to the doctor is gonna make you worse, right? It would have been better if you didn't have to do that, right? So one is that. And then two is in terms of just the time for people of, a lot of people have to, work a job and take care of kids or work multiple jobs, and just the time it takes to travel to, forget about the time in the waiting room and the time in the actual doctor's office, but just the transit time is just so long. If you go to a major medical center for your outpatient clinic appointments, it's a long time to park in the parking lot and walk to the clinic. You gotta do an extra 20 minutes just to park your car and get into the clinic. So now, are there things that absolutely cannot be done virtually from a physical exam perspective that have to be done in person? Of course. Does that mean that some visits you just can't do virtually because they require that type of physical exam piece? Absolutely. But there's a whole bunch of other visits where you don't really need that. Especially for your follow-up care for your diabetics and for your people with hypertension, where they can do their home glucose monitoring. You can send people blood pressure cuffs to people's homes. They're very inexpensive these days. And you can, so much of what we do with our patients is we talk about behavior modification and lifestyle, and sort of the fancy term for it's called motivational interviewing. Like it's not really interviewing them at all, but it's like kind of finding out like where they are. What's one of the big ones at the end of the day that we still have to do? Well, it's with smokers, right? One of my attending physicians in medical school is like, look, if you can get one smoker to quit over the course of your career, that's actually a huge accomplishment because it is just so bad for you, right? And so, like, do you have to come into the office for me to counsel you about smoking? No, like for you to have to, get in negative 30-degree temperatures for me to counsel you on smoking is ridiculous. So it really helps people address that access problem. It's not meant to be a cure-all for all primary care needs, but it absolutely has a place, especially for people who are in urban environments or in rural areas as well. Well, look, at the end of the day, I mean, it's just a hike. It's like 45 minutes or an hour to get to this place. A good friend of mine, his father is a pediatrician in New Mexico, and routinely the parents of his patients would drive an hour and a half to see him. And like to the extent that they wouldn't have to do that, I think that'd be hugely valuable.
Yeah, so with virtual care, it definitely helps a lot of people, and I think the argument definitely could be better than nothing. But the people who, I guess, push back on the virtual thing say, well, if you're only doing virtual care, that's not real care. I think Jay Parkinson, when he created Sherpa about a decade ago, called it virtual primary care, where you can do a lot of things asynchronously. So there are companies now that are virtual only, compared to other companies that are so-called virtual first, where they do have a backup brick and mortar. The way I personally see it is with these capitated models that aren't fee for service, because obviously the virtual thing doesn't work really well. You don't get paid to do virtual care. But these capitated models to bake in virtual is essential. But outside of that, what do you think of these like virtual only companies? Do you think they're filling a need, or are they just kind of going in and taking what's easy right now?
So the short answer is yes, I do think it fills a need, because at the end of the day, there are segments, healthcare is so big that there are niches that need to be served, and those niches themselves are huge because the whole ecosystem, for lack of a better word, is so big. And so are there, especially in, let's just call it employer-sponsored plans, I mean, kind of, employer-sponsored healthcare is kind of my area of experience, right? Right. Are there employees and employer plans where they have like very little, so your typical employer has only about 40% of their plan participants, adult plan participants have seen a primary care physician in the prior 2 years. It's only about 40%. Wow. So 60% have not. Now, those employers, many of them are highly resistant to fixed cost programs. And so they would be more than willing to get some type of primary care for their employees, but they're in no way, shape, or form going to pay $50 an employee per month for it. There's just no way. Their administrative fee for their TPA is about $25 per employee per month, and they have a network access fee of another $6 on top of that. So they're paying like $31. If they use a major insurance carrier, maybe they're paying $35 to $45 PEPM. So you essentially have to go to that employer and be like, okay, of all of your fixed costs, your administrative fee for your health plan is one of your most expensive fixed costs at $45 PEPM, and we're going to be like another thing equal to that. And their response is going to be like, it could be the best thing since sliced bread. There's no way I'm paying that. I refuse to. So you have to go in with something that is at a lower price point. And now, can you do a land and expand approach where you can offer a virtual only at a lower price point to start, and then build them into a hybrid or in-person version over time? Like, absolutely. But the percentage of employers that just are able to stomach the fixed cost for a direct primary care relationship, or even an on-site near-site clinic, it's just prohibitive. Like it's just not where they are. And frankly, they might never get there. So there has to be some sort of creative. This is my opinion. There has to be some sort of creative way on the part of primary care physicians to allow employers to get in at a lower price point. Are there other ways to let employers get in at a lower price point? Absolutely. I'm not saying this is the only way, but to the extent that we can do that, I think it'll help grow the entire movement over time.
Absolutely. And speaking of employers, 50% about, give or take, of Americans get their health insurance coverage provided by their employers, which means employers more or less control healthcare to some degree. And so there's obviously a lot going on in the healthcare space, be it value-based, be it direct care, and employers are busy running their businesses. So what should employers be doing to keep up with what's going on in healthcare, and what are some things that they need to know about?
Yeah, so at the end of the day, the vast majority of employers are exactly what you described, which is too busy running their business to care. And so they've really outsourced that caring to their broker benefit consultant. Now, the employers that actually do care about it, they tend to have at least 20,000 employees. So they have to spend now, you're talking, hundreds of millions, if not close to $1 billion on their entire healthcare spend for them to have a dedicated staff full-time within that employer like Boeing or Walmart or Disney or AT&T that actually has the experience and the acumen to all they do all day long is just think about that, right? And at the end of the day, there's just not that many employers with more than 20,000 employees. There's just not that many of them. You got the big states, you got the big municipalities, you got these major corporations, but at the majority of companies out there don't have that many people. Mm-hmm. And so it's just kind of a law of numbers that you're just, by definition, if you're going to be working with employers, you're frankly just going to be working with a lot smaller ones. And they're going to outsource that to their broker benefit consultants. That's really why they've hired them, is to be like, look, this is your area of expertise. You come in and have a meeting with me once a quarter, maybe twice a year. We talk about benefits and how we're going to structure our insurance and how much it's going to cost, but that's your job full time. And then you come in as a broker or consultant and you kind of tell me what to do, right? And if I don't like what you're telling me, then I always, as an employer, have a choice of finding a different broker consultant that I could do. And something they RFP it, and they go out and change it themselves. And so I think it's really a matter of engaging. For the majority of employers, it's a matter of engaging the broker and consultant community, and the broker consultant community. Just like it is a complex business to business sale. So, and I use that word specifically because there is a methodology and an approach to complex business to business sales, just like there is to the way you would treat DKA, right? It's like you don't have to make up how you would treat DKA, right? I mean, there's algorithms and there's a way. Okay, you got the insulin drip, you give them the insulin. You don't turn off the insulin drip until after an hour after you've given them the insulin, otherwise they'll go back. The gap will open up again, right? So there are processes and procedures and people who specialize in the complex business to business sale. And I would never expect a physician to be a doctor and also be really good at complex business to business sales. That's ridiculous, right? There's only so many things you can do, right? So to a certain extent, that's where there needs to be a dedicated, again, it could be outsourced to a marketing firm. It could, if you even hired somebody that just did this full time. So I'll give you an example. So there's an independent medical group in Charlotte, North Carolina that's called the Tryon Medical Group. And they have, it's a small team, but they got a small team of, salespeople that go out to employers. That's their full-time job. Mm-hmm. It's a pretty big group. I think they're 86 doctors, so it's pretty big. But the point is that you really have to have somebody pounding the pavement, every day, making the phone calls, doing the presentations, walking the buyer through the sales cycle to make that happen. And if a DPC practice approaches employers on their own, is that going to be difficult for them? Absolutely. Could they do it? Yeah, absolutely, they could do it. Where there's a will, there's a way. Doctors are very, motivated, creative, smart people. I mean, they can figure a lot of this stuff out. But at the end of the day, there's probably a lot of really great doctors as well that probably either don't want to or just can't, right? And so, to the extent that there can be, for lack of a better term, partnerships or just DPC groups going out and hiring, folks that can actually, assist them with that whole channel sales through brokers and consultants to employers, it's absolutely doable. You and I were talking before about how other DPC practices absolutely have a lot of employers. There's actually other specialties We talked about bariatric surgeons that actually have special outside firms that do patient acquisition for them as well. So I think that there is a path. This is a solvable problem.
So speaking of physicians, you mentioned the bariatric group, the DPCs that are going out and engaging, I guess, the broker community in the same way that the businesses are. Well, the brokers are really educating the businesses, and the physicians are educating the brokers. But this is a pretty small group of physicians. Do you see primary care doctors having any other role, or perhaps a bigger role in this grand, complex system of employer benefits?
So it's a great question. Short answer is yes. And in fact, there have been recommendations from a variety of nonprofit organizations, or just organizations that are in the employee benefit space, in regards to employer-sponsored plans, where they sort of put out best practices as it relates to running your employee health plan. And guess what? One of the things on that best practices is having like a medical director or a chief medical officer for your employee health plan itself. And interestingly, again, very large health plans absolutely have that. Like, does Walmart have their own doctor for their employee health plan? You better bet they do, right? Does Boeing? Absolutely, right? So these very large corporations do. But to the extent that smaller organizations have this, they do it. They can do it fractional, et cetera. So one of the case studies of this is Quest Diagnostics, the lab company, not externally, not what they do for their customers, but just internally for their own employee health plan. I think they had like 18,000 people on their own health plan, obviously phlebotomists, et cetera, all over the country. And they hired, I know this gentleman, fantastic physician, primary care doc, and they hired him to be the chief medical officer for the employee health plan. And guess what happened? The quality of the care for their employees went way up, and their costs went way down. It was incredibly successful. So interestingly, what caused that to happen? Quest got a new CEO, and they got a new CFO, and everybody who's watching this probably knows this. It starts at the top, and so really the sort of the classic statistic is that the typical American CEO only spends 30 minutes a year thinking about their employee health plan. So if they only spend 30 minutes a year thinking about it, they're not going to do anything drastic like hiring a doctor about it. However, there is a silver lining to the cloud, if you would, and that is that employee healthcare is a very countercyclical business where when the economy is expanding, like nobody at the business thinks about the employee health plan. They're like, it's expensive, I don't care, I'm just doing sales and hiring people and blah, 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 right? When the economy goes bad and sales go down and the company has to cut costs and they have to do things like layoffs, but then they also have to do things like, typically the employee health plan is the second or third largest expense for an employer after payroll, right? So they might have some sort of input like steel or whatever that might be more, but health insurance is typically number 2 or number 3. Then they actually start putting more scrutiny and more than 30 minutes. Maybe they spend 90 minutes a year, right? But they start putting more scrutiny on it. And when they do that, that's when the change happens. So really, so much of sales is about timing. And so it's really, we started Compass Professional Health Services in 2007, total disaster. I tried to sell to people for like a year. No one would return my phone calls, I was talking to myself, but then the recession happened. And I still had the same slide deck, I still had the same pitch and blah, blah, blah. But people started listening to me because they had the pain point of decrease in sales, and they actually had to do something about decreasing expenses, where they now had the quote unquote time of day to actually listen to me. So the practical thing that DPC practices can do is the key is you want to find an employer who's in pain. You can always find employers who are in pain, or brokers that have employers who are in pain. You can always find them. It's just a numbers game. You have to knock on a lot of doors. And during a recession, you knock on 10 doors, maybe you get 3 to answer. And when it's not a recession, maybe you only get 1 out of 10 to answer. And so then you have to knock on 30 doors instead of 10 in order to get those 3 people to talk to you. So it is, it's nothing that a little hard work doesn't solve.
Right. Well, one of the other things, besides for just the hard work, is You talk about this in a couple of your videos, actually. Medical education. We're not trained to do any of this, not just to do any of it, we're not trained to know any of this, even the basic financials of healthcare.
Right.
We have no exposure in medical school or in residency
Right.
training. So as it pertains to medical education, going up the pipeline to medical students and residents, what do you think are vital things that need to enter the medical education space?
It's a great question. It totally needs to be there, right? I mean, in all of my medical school and residency, like, it was never explained to me like how I was going to get paid. Like, never once. Like, oh, by the way, this is how you're going to get paid. Like, it is a very basic thing that should be explained to people, right? And it never is. So, like, I don't think you have to make it like a huge course or whatever. I mean, you could spend obviously months on it, but at a very basic level, to be like, look, this is how you're going to get paid, right? It's not that hard. But, so fine, my expectations are exceedingly low. That's all I think I'm ever going to get. The thing that medical school and residency does a fantastic job of is teaching doctors to be autodidacts. You have to educate yourself. Okay, you're out as an attending physician. Guess what? You still don't know what you're doing, right? You still have gobs that you need to learn. So you need to be a lifelong learner. And so I think, if anything, the medical school and residency, they just need to set the expectation. Oh, by the way, you got this training or whatever. Like, it's not enough. And it's on you for the rest of your career to figure out what the rest of that is. And like, don't come crying to me, complaining that I didn't teach it to you. You got to teach it to yourself. So, we're all grown-ups here, and you've got to be an autodidact. And physicians are fantastic autodidacts. There's not a physician that I have not met who like can't learn. Like, it's not that complicated. Like, anybody can learn this stuff. It's just a matter of making it happen.
Right, that's a great point. And there are plenty of resources out there, just like the videos that you're putting out.
From you and Paul is, and from a gazillion other people. Yeah, yes, absolutely.
Right, yeah, no, it's awesome. And so to conclude, I like to give a big overarching question, which is the future of primary care. There's so much going on right now in primary care in terms of payment models and health tech, legislation even. Where do you see the future of primary care going? And well, let's just do that one first. What do you see in 10 years? Which way is primary care going?
Yeah, unfortunately, as with many things, it has to get worse before it gets better. So I think that don't ask me why the world is set up this way, but it's one of these things where just like, pain causes change. Right? We see that all the time with our patients. Sometimes our patients kind of have to get worse before they're, willing to, like with the smoking example, maybe they have to have a really bad case of pneumonia or have a heart attack and be like, look, you gotta stop smoking. You just had a heart attack. Sometimes it's gotta get worse before it gets better. So if anything, I think that that process just needs to happen. And as it happens, so what does that mean, get worse before it gets better? That means the working conditions for frankly, just the patient care working conditions for all specialties, they have been getting worse. Obviously, the fact that we've had 117,000 physicians leave the practice of medicine, people are voting with their feet, and they're like, take this job and shut it. Like, forget it. Like, I just don't want to do this anymore. Is to be like, okay, you don't have to leave the practice of medicine. There are other ways for you to practice medicine, like direct primary care. So there's like a push and a pull, right? So you and so many other people within the DPC world have been like, look, DPC is not that scary. Like, here are the things you can do. Like, you can do this, right? So that's the pull, but then there's got to be the push. And the push is that, okay, my current job is just so bad. And so the badness of that current job, frankly, is just going to get worse over time. And then people are finally going to more and more take the leap and be like, okay, I don't have to leave medicine. I'm certainly not staying in the position where I am now, but there's a third alternative, and that's DPC.
Gotcha. So I guess your thesis right now is that things still aren't as bad as they could be, but they're heading that way, and as different opportunities present and things get worse in the current system, you'll see a natural migration.
Oh yeah, I mean, listen, at the end of the day, all these employed docs at hospital systems, like we're talking about Medicare pay cuts, like forget the Medicare pay cut, the hospital system could just say to them, look, we're cutting your pay. And there are so many cities in America have so few major hospital systems that if they say to them, look, we're going to decrease your salary by 10%, but no, I won't name the health system, but another health system in a major city did that to their pediatricians. They said, you're going to, and guess what happened? The pediatricians ate it. They just got paid 10% less. Because what are you going to do? You're going to walk? And then it's like, okay, where you are? There's only 2 other hospitals in town. And oh, by the way, we've got you signed to a non-compete agreement. So what are you going to do? You have to uproot your family and move to a totally different city to make it happen. So there's going to be more downward pressure on these primary care docs to see more patients and get paid less to do it. And again, I'm not trying to be doom and gloom, but like that'll get to the point where people are like, okay, I'm done. I'm going to do DPC instead.
Yeah, so for the people who need the push, because there are those of us who are responding to the pool, for the people that need the push, what can we be doing right now, whether it's physicians or brokers or just anybody, what can we do in primary care to kind of make the pool stronger and to create other opportunities?
Things like these conferences are very good. I think video is super powerful. So to the extent that you can have every DPC doctor in America making their own YouTube channel about how how they did it and telling their stories about it is super helpful for people to be like, listen, podcasts are great, blogging is great. There's something very powerful about video because we're very visual creatures, right? I mean, literally, you can capture somebody's attention so much better if you can actually, we respond to faces better than we do to anything else. So it's just a matter of the megaphone. So to the extent that, like, I think the positivity of direct primary care is there. And is there a megaphone? Absolutely, there's a megaphone. But I think that megaphone can be turned up even more. And also too, it just takes time. Like I think all doctors to a certain extent are very impatient, myself included. But it just takes time. This all just kind of has to play out. And it takes so much time that I know that, like, even over the course of my career and my lifetime, like, it's never gonna be where it should be. Like, and I'm okay with that. Like, it's gonna be like where we actually have a robust primary care infrastructure in America. Like, that's my vision, and I think we can get there. Like, that's not gonna be during my lifetime, and that's okay. But at least we can push the ball down the field while we're here.
Awesome. Well, thank you so much for sitting with me today. It was awesome getting to
Dr. Qiu, thank you. Thank you for having me. Thank you for watching. I'm Dr. Eric Bricker with Simple Pay Health.
And I'm Dr. Kenneth Qiu with X = Primary Care.